Hello, everyone, and welcome to today's webinar. My name is Christine Sardo Molmenti. I'll be speaking about young-onset colorectal cancer. What are the risk factors? Thank you all for joining, and we'll have time for questions at the end. So first, just a little background on colorectal cancer. Worldwide, there are more than 1 million new cases and about 500,000 deaths every year. In the United States, it's the third most common cancer and the second leading cause of cancer-related deaths. The colorectal cancer is a very slow-growing tumor. Estimates suggest it takes decades for a tumor to develop, and it all starts with a polyp. And a specific type of polyp is one of the most inciting factors, and this is called the adenomatous polyp or an adenoma. More than 95% of sporadic colorectal cancers arise from this type of polyp. Only about 20% of colorectal cancers are due to familial or genetic mutations. About 75 to 80% are due to sporadic reasons. So 30 to 40% of the population will develop an adenoma by the time they're 60. And there's evidence that the prevalence of polyps are similar in patients 40 to 49 compared to those 50 to 59. If a person has had an adenomatous polyp, there's a 20 to 50% chance that that polyp will come back within 3 to 5 years. The fact that it will come back depends on a number of factors. One, on the type of histology. Villus architecture is one of the features of an adenomatous polyp that may predict its recurrence. The size of the polyp, how many polyps were removed, where it was, if it was in the proximal colon or the right colon or the distal colon, and also depending upon if it's an advanced or non-advanced lesion. The current trends in colorectal cancer are quite alarming. On one hand, they're actually very good for the over 50 group because we've seen about a 30% decline in the last decade or so, mainly due to screening in a larger proportion of the population. But what's alarming is that we're seeing an increasing incidence of colorectal cancer among individuals under 50 years of age. In fact, there's been a 51% increase in incidence since 1994. And this incidence rate has been increasing at about a 2.1% rate per year among colon cancer patients, but a much quicker rate among those who have rectal cancer, and that rate has been increasing by 3.8% per year. This rate among the younger, under 50 population is expected to increase over the next 10 to 20 years, and you'll see from this figure that the biggest increase is anticipated in individuals 20 to 34 years of age. So this is of great concern and a great public health concern. Young onset colorectal cancer, I just wanted to go through some of the key features. First, there's a later stage at diagnosis. When the cancer is diagnosed, the lesions are more advanced. There's higher prevalence of mucinous or poorly differentiated tumors, which have a much worse prognosis. There's a delay in diagnosis and a poor overall 5-year survival compared to people over 50. Among young onset colorectal cancer cases, it mimics the over 50 where 75 to 80% are sporadic. So we don't really know what is leading to these sporadic cancers with only 20 or so percent that are due to family history. The reason that there's a later stage diagnosis is that these patients aren't being recognized. When a young person goes to their family medicine physician or their primary care with bleeding, abdominal pain, and other symptoms, they are often left with a diagnosis of irritable bowel, hemorrhoids, or other GI conditions, and young onset colorectal cancer is not identified early. So they end up going to a number of physicians over time, and after a year or two goes by, of course, their diagnosis has been delayed and their lesion is much further advanced. And this is an issue because when we look at 5-year survival for colorectal cancer, when an individual is diagnosed in the early stages or the localized stages of the disease, they have a great chance of survival. 90% are surviving after 5 years. And as you see, as we get further down the line to regional and distant cancers, there is a much lower rate of survival after 5 years. And just to demonstrate this a little more clearly, The localized cancers would be the in situ or localized cancers on the left here, where it hasn't fully invaded into the wall of the colon or rectum. So there's still a big opportunity for treatment and a big opportunity for survival. Once you get into regional and distant cancer, where it's spread through the wall of the colon and it may have invaded nearby tissue or nearby lymph nodes, that's where you really get into trouble. And that's where we see dramatic declines in survival rates in people with regional or distant disease at time of diagnosis. The good news is that there's a number of factors that are within our control that decrease risk, and then I also want to point out those that increase risk. So the factors that increase risk are on the left, and these are hereditary and medical history, and there's a number listed here. Family history and having a first-degree relative or FDR with colorectal cancer, and having more than one relative with colorectal cancer dramatically increases your risk. In fact, the relative risk is 4.0. So you have a fourfold increased risk of colorectal cancer if you have a first-degree relative or greater than one relative with the disease. If you have an inflammatory condition related to GI health, things like Crohn's disease, ulcerative colitis, your risk also increases. Diabetes is also a risk for colorectal cancer. And then there's a number of behavioral factors that are within our control: alcohol consumption, obesity, red meat, processed meat, and smoking. So when we look at factors that decrease risk, it's sort of the other side of these behavioral factors that increase risk. So if we exercise more, consume more dairy, fruit, vegetables, more fiber, and aspirin use is one of the most significant behavioral risk factors that can decrease our risk. When I mentioned that colorectal cancer is a very slow-growing tumor, it's the fact that it has to go through a number of processes in order for cancer to develop. And there's a well-known sequence called the adenoma to carcinoma sequence. So here we start with our normal epithelium, and over time, it takes several steps for the normal epithelium to transform into something that's benign, such as an early polyp, or a little later stage, which can be a late adenoma. As I mentioned, that's the one that is most significantly linked to colorectal cancer. And then further to develop to full onset cancer, this can take up to 10 or 20 years. So what are some of the risk factors for early age onset colorectal cancer? There are a number of questions, and no one really understands why this is increasing in this younger group. Questions may include, are they environmental? Are they related to lifestyle? What is the timing of exposure? We talk about prenatal and early age exposures. Where is the optimal place to intervene, and are the risk factors modifiable? In addition, we know the number of these established risk factors, as I just mentioned, are associated with over 50, but are they also associated with under 50? And this is still unknown. So my aims for today are just to characterize some of the modifiable risk factors that are relevant to this early age colorectal neoplasia, and summarize some of the potential biological links. I've been looking at the literature for young onset colorectal cancer over the last year and a half or so, and I've identified about 141 articles. I think there's about 150 now today. And the majority of these articles that have been published, which is not that many, are mainly in the under 50 group. And there's a lot of inconsistency in terms of how people define young onset colorectal cancer. Some say it's under 50, under 45, under 40. The majority of articles that I found so far are under 40, and that's how young onset colorectal cancer is being defined, although more generally it's under 50. The years of publication, as you can see, the earliest publication was in 1939. However, over the last few decades, we see a dramatic increase in the last 5 years, with 40% of the publications published recently. As I go through some of these data, I just wanted to provide a quick outline and background on the type of epidemiologic study designs that I'm going to cover. So first, there's two main types of epidemiologic study designs. There's descriptive and there's analytic. The descriptive studies are mainly those that describe a disease. They may describe the distribution of the disease, the patterns, the characteristics in a population, the time and place where it occurs. And these types of studies are all hypothesis generating. So you're just looking at the population to come up with some potential links that you may think you want to test in an analytic or experimental study. So an analytic study are those that are experimental or observational. So either we're going to conduct an experiment where we randomize participants to two different groups and we intervene somehow on their either lifestyle or we provide a drug. And we always have two different groups that are randomized in experimental trials. Observational studies, we only look at a person in their natural environment. We don't intervene in any way. We enroll people into a study, and over time, we look to see if they've developed the disease in the case of a cohort study, or we enroll people who already have the disease, and we look back to see what their exposures were, as in a case control study. And these types of studies are hypothesis testing. So whatever you found in your descriptive study that you maybe wanted to test, you would then generate a hypothesis and then test that using these analytic methods. So given this background, the risk factor related studies that I found related to young onset colorectal cancer include a number of observational studies, no experimental studies, and no descriptive studies so far. But there are 18 observational studies, 7 are cohort studies, and 9 are case control. They've identified a number of different areas of study from obesity, diabetes, occupational exposures, physical activity, and some dietary exposures. Now, of these 18 studies, 12 related to obesity and early age onset colorectal cancer. So of these 12 publications, here we see that there are 7 that are cohort studies. And among all these cohort studies, there's something interesting to look at here. If you can just look at first the column with age. If you look down and look at the age groups that were studied in each of these populations, you'll notice that none of these were purely under 50 or under 40. So there's a lot of information on how early age obesity is associated with adult colorectal cancer. However, we're not sure from these studies how they exactly are affecting the under 50 population. There were 5 case control studies, and of these case control studies, there's only one highlighted at the bottom here that specifically looked at young onset colorectal cancer under 45 in this group. And I just wanted to highlight a couple of these studies very quickly. The reason that we're interested in obesity is because there's about a 50% increased risk of colorectal cancer in men if they have a BMI that indicates they're overweight, which means it's between 25 and 30. And about a 2 times increased risk of colorectal cancer if their BMI is over 30 or if they're the obese category. And we see similar increased trends for women. One of the reasons why obesity may be related to colorectal cancer is that the distribution of fat and the metabolically active components that are in fat, such as inflammatory cytokines and other mediators that could lead to tumor initiation, tumor progression, tumor promotion. These are all very prominent in people who have excess body weight, and especially when that fat is located around the abdomen, and there's a specific type of fat called visceral adiposity. And this type of fat has specifically been associated with not only colorectal cancer, but a number of metabolic diseases and dysregulation. In fact, of all the people who have metabolic syndrome, the most common cancer diagnosed among that group is colorectal cancer. So we know that obesity, metabolic dysregulation, as you saw earlier, diabetes is also associated with colorectal cancer. So there's a lot of risk factors that really have to be studied and taken into account when trying to figure out young onset. So of these studies that were conducted, as I mentioned, there are diabetes, physical activity, dietary factors. And of these, I'm going to really just focus on this one cohort study that examined diabetic patients who were greater than or equal to 45 years of age. And in this one, they did find that there was a potential relationship with diabetes and early colorectal cancer. In fact, diabetic patients and their controls were followed from 2000 to 2006. And there was an overall significantly high risk of developing a colon neoplasm or a malignant cancer. And there was about a 30% increased risk. Of the case control studies, that have looked at young onset colorectal cancer. As I mentioned, there was one specifically, this Rosato study, that was conducted in patients under 45. And then there's another study as well that was conducted that was in the age group of 25 to 44 years of age. So in the Rosato study, I'm just going to go through these very quickly, they found an association with alcohol and processed meat consumption. And these factors were associated with an increased risk of colorectal cancer in this under 45 group. So they found about a 56% increased risk of disease among those who consumed more than 14 drinks per week of alcohol and red meat. Also in this study, they found that there were a number of dietary factors that decreased risk. Everything from vegetable consumption, citrus fruit, fish intake, beta carotene, vitamin C, E, and folate. And we saw significant reductions in all of in colorectal cancer among these risk factors. However, this study did not find a significant association with physical activity, overweight, and diabetes. So there is some inconsistency among these studies. In the Peters study, the objective was to evaluate risk factors related to rectal cancer in 3 subdivisions of the colon. And in this study, they found that deep fried foods were associated with right-sided colorectal cancer, fried bacon or ham, right-sided colorectal cancer, barbecued and smoked meats, and consumption of fresh and raw fruits was associated with a decreased risk. And deep fried food consumption was associated with rectal cancer. They also looked at sedentary time and job-related activities, and those who held a sedentary job for the majority of their lifetime, they had about a 70% increased risk of sigmoid cancer. And these are just some of the cancer locations I'm sort of covering here. Proximal is on the right side. So if you think about when you have a colonoscopy and the colonoscope enters here through the rectal area and the sigmoid colon, to get the colonoscope all the way around to the edge here, it can be very troublesome to get to the right side of the colon. So these right-sided cancers and people with that disease are a particular risk. Some of the mechanisms for these risk factors include, and here's our diet and sedentary behavior on the left. Some of the mechanisms include increased adiposity, as I mentioned before, and the infiltration of inflammatory cytokines and other mediators that may promote the disease. And then a number of other things may be mediated through this adiposity mechanism, having to do with different hormones, metabolic dysregulation, as I mentioned, insulin resistance and possible glucose intolerance, inflammation. These are some of the key markers associated with inflammation, TNF-alpha and IL-6, C-reactive protein, and then decreased vitamin D may also be one of the mediators of this association. Gut microbiome and the bacteria in our gut is also hypothesized as a potential mediator. So when we think about colorectal cancer, we have a number of places to intervene. And so when we talk about young onset colorectal cancer, we're really focused here on initiation of the disease. And initiation is characterized by the first change or adaptation of the DNA. So if you have any kind of damage or some kind of reactive oxygen species or insult to the DNA that can trigger the cell to be initiated, that cell over time divides, and that cell that is once normal has become abnormal due to the DNA alteration, continues to multiply, divide, proliferate over time, and it's years later that you see a benign polyp in the colon. And here you have a chance for reversal of that polyp or removal of the polyp. But if not, it pushes you forth into colorectal neoplasia. So with young onset colorectal cancer, we're really focused on this birth to colorectal neoplasia, this first arrow, to see where we can affect change and identify these risk factors. So the reason that I'm interested in that early stage and looking at before a person develops a polyp is that I've been involved with a study called the wheat bran fiber and ursodeoxycholic acid study that was a chemoprevention trial looking at ways that we can prevent recurrence of colorectal adenomas. And so I've used this large database to do a very quick analysis of those who are under 50. And there was only about 100 patients who were in the 40 to 50-year-old age group. We wanted to see what are some of the factors associated with colorectal adenoma recurrence in these young individuals. And this very briefly, the preliminary results indicate that among those under 50, which is in the left-hand column, compared to those those under 50 less likely among those under 50 and more likely among those under 50 is that this younger group in the right column here are more likely to consume saturated fats, be current smokers, consume more red meat, and have a more pro-inflammatory diet as measured by the Dietary Inflammatory Index, which is a measure that takes into account all the foods that someone eats on a regular basis and determines what their dietary inflammatory potential of their diet is. So this under 50 group, they're more likely to engage in these colorectal cancer promoting behaviors potentially, as far as this study is concerned. So what are the implications for young onset colorectal cancer? From this study as well, we also found that history of previous polyps in the younger 50 group are a stronger risk factor for recurrence compared to those over 50. Unidentified risk factors that contribute to the formation of adenomas in younger individuals. So we still don't know what some of these underlying risk factors may be. And then efforts to further investigate specific risk factors and the biologic and molecular basis for increasing incidence and mortality in this young group are much needed. So as a summary, I'm just going to go through some of the key risk factor data that I've discussed and some of the other things that have been characterized in the literature. So there's a suggested link between early obesity and young onset colorectal cancer. And remember, this was in those cohort studies that weren't specifically looking at the under 50 group, but were including a large range or a wider range of the population. There's evidence of an association with diabetes, but this is still unclear. There's a number of dietary factors. Dairy, there was one of the studies that looked at school milk consumption and how that impacted colorectal cancer in adult life, but that was inconclusive. There are a number of occupational exposures that increase, such as sitting. People who have sedentary jobs and sit for the majority of their day may increase risk. And then, as I mentioned, there's a number of these metabolic factors related to obesity, metabolic syndrome, metabolic dysregulation, and smoking, which are associated with increased risk of colorectal cancer. So from the study that I showed you, the preliminary results indicate that there's that deleterious lifestyle factors are more likely in this under 50 group. As I mentioned, they were more likely to be smokers, have a more inflammatory diet, consume red meat and saturated fat. So there's still a lot more work to do. This is where we are so far at this very early stage of trying to understand the risk factors. And our next steps really are to design other studies. As I mentioned, there was only a couple case control studies that really studied this under 50 or under 45 group in specifically. And cohort studies, take a long time to conduct because you're starting with people who don't have the disease and waiting for the disease to occur, but there's still things that we can do in terms of designing cohort studies, randomized clinical trials. So as much as we can do to try and gather more evidence among different types of study designs will be helpful in this investigation. And then can we identify potential biomarkers in this younger group and look at potential mechanisms of action? What are the main channels that this is being implicated, and how can we reduce risk by looking at some of these markers? And then can we explore other environmental and behavioral risk factors? Maybe we can use a risk assessment model. Maybe we can come up with a risk assessment tool that we can enter in people's data and try and determine if they're at increased risk or average risk. And in this under 50 group, help primary care physicians and patients to better understand the disease so that we can prevent the delay in diagnosis and the advanced stage of disease at time of diagnosis. So if anyone has any questions, please feel free to contact me by phone or by email, and I'd be happy to take your questions. Okay, so we have one question. The person asks, what are the most cost-effective ways to stop the rising trend in young onset colorectal cancer? And this is an excellent question because as we know, healthcare costs are extremely high. We know the cost of screening can be extremely high, especially when people don't have coverage. So one of the best things that we can really look to at this stage with the information that we have is to try and figure out ways that we can really help people impact their lifestyle. And there's a number of ways we can do this. And we need kind of takes a village to do this, because not only do we need the patient and the public to be educated on some of these risk factors, but we also need primary care physicians and other healthcare providers who are the point of contact with individuals and patients to help disseminate this information. So if we could figure out some way to educate the provider, educate the patient, and find ways that we can get the word out in a very cost-effective manner, where maybe we get a number of ambassadors on board who can educate schools, that can go to college campuses. There's so many things that people can do in terms of looking at body weight, looking at red meat consumption, saturated fat consumption, alcohol consumption especially, because there's so many convenience-oriented outlets for the public that the easier choice is most often the unhealthy choice. So if we can help people figure out ways to change their lifestyle, eat better, move more, maintain a healthy weight, I think that's probably one of the best ways to cost effectively approach this. Okay, I see another question. Oh, here we go. Is there a mammogram for breast cancer? Is there any screening for this? Oh, there's mammogram for breast cancer. Is there any screening for this? Yes, absolutely. So colorectal cancer screening is done in a number of ways. There's first the colonoscopy, which is really the gold standard in terms of early detection and prevention of colorectal cancer, because number one, you can detect a cancer early, and number two, you can prevent cancer by removing polyps. Colorectal cancer screening is recommended for adults at age 50. That's average risk adults at age 50, meaning that they don't have a familial component. They don't have familial adenomatous polyposis, or FAP, which is a condition where a person has the propensity to develop thousands of polyps in their colon by the time they're 40. Lynch syndrome is another familial condition. So anyone with those earlier conditions are screened before 50, but any average risk adult is screened at 50 years of age or older. If you're African American, the screening age is 45. If you're under 50 and average risk, screening is not recommended. Also, there are a number of other types of screening modalities. There's the FOBT, which is the fecal occult blood test. So it's less invasive than a colonoscopy. There's the FIT test. There's a number of ways that you can monitor colorectal cancer and screening for colorectal cancer. Those tests are done more frequently. If you have a colonoscopy, depending on the results, if you have a benign polyp, you're generally not recommended to come back for 10 years or so. If you have any kind of adenomatous polyp or any adenoma features, you're generally, depending on the number, as I mentioned earlier, and the size and the type, you could come back anywhere from 1 to 5 years. But the fecal occult blood test and the FIT test and other non-invasive tests are definitely opportunities for people to screen if they're not willing to go through colonoscopy. There's currently a national initiative to have 80% of the U.S. population screened by 2018. And in New York City, there's been a special push for colonoscopy screening, which has been highly successful. Now there's a large percentage of the New York population that has been screened, and some of those other models for screening are being adopted around the country. If anyone has any additional questions and would like to contact me afterward, I'm available anytime by email. You can call my office. I'd be happy to schedule time if you wanted to discuss any of the details or have a specific question. But thank you very much for participating. Thank you for taking the time today, and I look forward to meeting some of you in the future. Thank you.